Right, so what has changed since EVS? Right, so number one, what have we learned from EVS? We know that systemic antibiotic, there is no difference in the final visual acuity if you receive or not receive antibiotic. And the early vitrectomy was significantly higher visual acuity if you do it only if the light is perception of light. And there was no difference if the vision is hand motion. But what is against EVS? Well, it was done in 1995, 22-year-old, so it's not as sexy as 2 years old. Concept, as Ahmed said earlier, abscess, general surgery, you have to clear the toxins. And they limited our ability to do vitrectomy early, so we would like to go and clear all the stuff from there. And we have nowadays new vitrectomy, small gauge. We are faster and safer than these ancient people. But if you look carefully into the old EVS, they have the same concept. They said, yes, theoretically, if we clear the toxin and the membrane, we will have a better outcome. But you have to look at how they tested the hand motion or light perception. Well, definitely it's different from the way I tested the hand motion in several hospitals in UK. So they put a lamp behind the patient. They put the hand of the doctor 60 centimeters from the patient, and you have to do one movement per second, and the patient has to report 4 out of 5 to qualify for hand motion. If they do 3 out of 5, that's perception of light. So you have to keep that in mind. Regarding the systemic antibiotic, nowadays we have the 4th generation fluoroquinolones, and to be quite fair, they stated in their conclusion that their conclusion was limited to the antibiotic that they used at that time. But how they performed the vitrectomy? Remember, these are difficult cases. First lesson you learn as a VR fellow, you have to have a good visualization. So visualization is essential. You have cloudy cornea, you have AC full of fibrin, membrane. These cases might be a complicated cases. IOL might not be stable. You might need to take the IOL out, removing this membrane, dilating the pupil. And doing a PVD retina, you are just expecting tears in this retina. Right, these are 2 cases. The one on the right, these are less aggressive. I'm telling you, this will get better by its own. Give the injection and they will get better. On the left, that's the one which require a vitrectomy. So the cornea is cloudy. Would you go and do a full vitrectomy on that cornea, on that eye? So we are faster and safer. But sometimes when you are fast, you get that at the end. Are we safer? These are 2 papers. The first one, they looked at the risk of iatrogenic tear happening in 20-gauge vitrectomy. This is from Moorfields. And they did it on a quiet eye, macular hole or epiretinal membrane, simple vitrectomy. And the intraoperative iatrogenic tear was 15.2. Another paper from New Zealand. They did the same, 23 and the 25 gauge. And guess what? It's the same incidence, 15.7. So are we safer or not? You have to doubt that. So what has it changed? We know that I'm happy with the rest, but I will concentrate on 2 points. Number one is steroid. Do we need to give the patient a steroid at the beginning? I will wait for 48 hours. I don't want to mask the improvement effect by my steroid. So once the patient starts to have an improvement, I will give the patient a steroid. And I want a clearance from the lab. So I will wait if there is a fungus or something. And the second point, I don't care if you are doing a vitreous stab or vitreous biopsy, as long as you take a sample and send it to the lab. And most importantly, as Ahmed said, it's to give the antibiotic. Vitrectomy, they used to do about 50% of the remove 50% without inducing a PVD, and I will do exactly the same. You have to think about the complication of the EVS. They have 5% retinal detachment and 3% phthisis. So when you are doing these cases, you might end here. So you have to justify the way that you manage the patient. I'm originally from Egypt, and that's an ancient way of farming in Egypt. This is about 4,000 years ago. And that's 4,000 years later, we are doing the same stuff. Maybe I'm not changing. Moved to UK for the last 20 years, and Adam Brooke Fellow in Cambridge, they are still using the indirect ophthalmoscope to do the vitrectomy. They have to learn that as a part of their fellowship. So maybe Egypt, England, right. Conclusion. Randomized controlled trial remains the superior method of assessing any efficiency of a medical intervention. If you want to challenge that, you have to challenge it with another similar trial. Vitrectomy is difficult in these cases, especially with the corneal edema, fibrin in the AC, capsular thickening, and poor visualization will make vitrectomy difficult. The fight is still going on, and I think it's better to leave now. Thank you very much.
I agreed with all the things you said, but I do not agree that we have to do a 50% vitrectomy. I totally disagree with that, because time is changing, and I try to do a more aggressive vitrectomy. I try not to aggressively pull the PVD, try not. I try to remove the pus with active suction, even on the macula. And the last thing I would like to say that in endophthalmitis, vitrectomy should be done by experienced surgeons. It's a difficult surgery. We should not make any retinal breaks, but still, I try to do a total vitrectomy, which I do not follow the EVS study. It's an old study. We have to change something. That's what I believe.
Yeah, I take your point.
On the floor.
One question about your use of steroids. Did I understand right that you were waiting 48 hours before you started because of the fear it might be a fungus? But if you have like an endophthalmitis 24 to 40 hours after cataract surgery, plurant, a lot of hypopyon, and we don't want to discuss how to treat it, but then afterwards when the eye is pain-free, you still wait 48 hours to fight the inflammation, not the infection?
Right. Yeah, you need to treat the infection first before starting the steroid. If you give the patient a steroid, might make the patient feel better. So you will wait till you get that sign from the patient that he's seeing better or feeling better, and then you can treat the inflammation later. But you need to sterilize the eye first with the antibiotic. That's the way I manage my patient.
Thank you, but maybe I got it wrong, but other persons have even advocated to give the steroids even directly when they do the injections. I think Professor Flint said it. What was it? 0.4 milligram, 4 milligram dexamethasone, for example. Maybe some of the more experienced can comment on this, please.
So basically, I do not use steroids at all. So the majority would do so for obvious reasons from the rationals, but I've seen personally no difference, and they do also very well without steroids. So this question has not been solved so far, as I know.
Yeah, I'm a vitrectomy person, so I remove everything, and I don't see the need for steroids once you've done that. Shangu?
I personally use intravitreal steroids associated with intravitreal antibiotics together all the time. Three. I mean, cefuroxime, and ceftazidime, vancomycin, and steroid, all three together in all of my cases, because inflammation itself gives a lot of damage to the retina, and I would like to control that inflammation at the moment. And my feeling is
during vitrectomy or
no.
no.
During,
This is The injection.
Yeah, without vitrectomy.
So, okay, so
If
injecting,
I'm
he's
doing
saying.
the injection,
Yeah.
I give the steroid at
Okay.
the same time.
Yeah,
If
okay.
I do the vitrectomy, I usually put silicone oil, so
Okay,
no need for that.
yes.
Just a week ago, Jan van Meurs reported on the Eurasian randomized prospective study on injection for endophthalmitis, and he found no additional benefit of steroids simultaneous to intravitreal antibiotics.
Yes, one final comment.
There has been controversy, and there were controversial studies. The study mentioned is one of the new studies. There's a study as well from Jerusalem that showed, actually, interestingly, there are less number of re-injections of antibiotics when you use steroids, because then you're deciding early on whether the patient is improving or not. So it might be of benefit, because you know if the patient is improving. I think it might be reasonable to use it, but better not to use Kenalog, because if you have inflammation from Kenalog, you're confusing yourself more. So dexamethasone.
Mm-hmm.